Assalamu alaikum. I know it's the last session of the day, but صراحة always it's the closest sessions to my heart, the challenging cases. Because as they said, in certain situations, what better thing to learn you other than a real patient story? So I'll try to tell this story as it is, to emphasize that we're not flawless and the learning process is going on. So our patient background, she's a 12-year-old female diagnosed with Crohn's disease 2 years before she referred to our rheumatology clinic. And she started on anti-TNF infliximab. A few months later, switched to adalimumab because of the disease flare and antibodies developed. Her family history was quite significant. She has essential hypertension in her mom and one of her siblings. Also, her father diagnosed with Crohn's disease, later on developed colorectal cancer, and he passed away at age of 55. 2 years after her initial diagnosis, she referred to our clinic complaining of chronic back pain that lasted for 6 months, quite persistent, non-radiating, increased with the activity, severe enough to interfere with her daily activity, associated with arthralgia, myalgia, fatigue, headache, and there was the school absences because of that pain. She denied any morning stiffness, fever, rash, Raynaud's phenomena, oral or genitalia ulcerations. On her examination, she looked pale, overweight. Her vital signs was within normal, and she was tender, sore everywhere, in the paraspinal area, outer points of the breast, hips, near to elbows, kind of evolving pain amplification. And there was tenderness over the sacral iliac joint, mainly the right side, and there was no obvious arthritis manifestations. Her chest, abdomen, cardiovascular examination within normal, peripheral pulses intact, synchronized. Her investigations revealed significant increase in her inflammatory markers, thrombocytosis, and just normal C3, C4, negative antibodies, and there was only positive lupus anticoagulant. At that stage, we thought, typical thinking, this is, she has IBD, now have a chronic back pain, it could be just axial spondyloarthropathy, and we requested MRI for sacroiliac joint looking for sacroiliitis, came to be negative, and HLA-B27 negative. So would you be more suspicious at this stage? To be honest with you, I couldn't ignore the high inflammatory markers. I contacted the GI consultant asking him, are you sure this is IBD? Well, he didn't like my question, but yes, he was sure that this is Crohn's, radiologically, histopathology, beautifully matched Crohn's disease. So she didn't give us that much long time, and 1 month later she decided to have progressive headache, fatigue, hypertension, which was investigated thoroughly, CT done, ophthalmology examination, renal ultrasound. We repeated autoimmune serology just in case we were kind of early when we requested 1 month before that, and cardiologist, nephrologist, endocrinologist teams consulted to rule out secondary causes of hypertension. She started on antihypertensive medications, and 4 weeks later, she presented with serositis manifestation, pleural effusion, congested lungs, and her symptoms progress, her hypertension persistent, and inflammatory markers high. She has anemia, which was longest-standing anemia, and she was treated with IV iron. And there was acute kidney injury. There was a raise in PUN and creatinine. So this is the timeline, just to summarize the events. 2020, she diagnosed with the Crohn's. A few 1 year later, she developed infliximab antibodies, and she switched to adalimumab. And then 1 year later, she developed kind of myalgia, fatigue, persistent lower back pain, and also iron deficiency anemia. So 1 month later, she developed all that other complications, which are sinusitis and hypertension, acute kidney injury. So just to share your thought process, if you would press, well, nothing to press on. So you can throw out whatever words come to your mind. What's your differential diagnosis until we solve this? Lupus. Other than lupus? Vasculitis. Other than vasculitis? Behçet disease. Good thinking. To be honest, it was it was on top of my differential diagnosis, Behçet disease. So you can scan the barcode if you have any other differentials. If you don't, that's fine. So in interest of time, I'll move. Lupus, Takayasu's arthritis, Behçet disease. Good thinking. So we kind of thought of everything. We thought of Behçet disease. It could be, who can differentiate between GI vasculitis and Crohn's disease? To be honest, it's kind of difficult. So I thought it could be just Behçet presenting with the GI manifestation Crohn's-like. And we thought of paraneoplastic phenomena, given the fact that her father passed away because of the colorectal cancer. It could be pheochromocytoma, carcinoid tumor. We thought of para-infectious process. She was on anti-TNF for 2 years. And drug-induced lupus, as the anti-TNF, one of the most common causes of the drug-induced lupus. And antiphospholipid-related phenomena, I couldn't resist actually that differential because there was only one positive lupus anticoagulant, other vasculitis, and rarely we thought also of sarcoidosis. So investigations showed anemia, thrombocytosis, significant high inflammatory markers, significant increase in the cardiac enzymes, and there was BUN creatinine high, and other investigations were unremarkable, including urine analysis. There was just microscopic hematuria, there was no proteinuria, and viral serology all came negative, including also the TB, which could be manifest as such presentation. We sent for urine catecholamines to tackle the pheochromocytoma. It was negative. The only pending investigations at that stage was AC level and antihistone antibodies. As we thought of drug-induced lupus, 50% of patients have positive antihistone antibodies, and IgG subclasses, just in case this is a vasculitis. So this is to summarize the case. In the context of Crohn's disease on anti-TNF medication for the last 2 years, suddenly developed lower back pain, hypertension, sinusitis, acute kidney injury, and significantly increase in inflammatory markers, including serum amyloid A. All autoimmune serology negative except for lupus anticoagulant. So I guess the big question here was, are we dealing with only inflammatory process, or this is inflammatory and ischemic process? Shall we go further imaging? Shall we wait for the testing results of the autoimmune serology, or should we go for a biopsy? Also, if you were in our situation, what would you do? If you can scan the barcode quickly and give us the response. Nobody responded? بالأولاني؟ طيب, okay. Interest of time, so yeah, I just want to go back to my slides. ما نبي voting, هونا. So, this is, actually this was our action. We decided that, all nephrotoxic medications out. We will stop the anti-TNF Humira, switch to azathioprine to tackle both IBD and sort of either drug-induced lupus or vasculitis. We took a biopsy, definitely, from the renal, as it is the biopsiable tissue here. Abdomen CT, the revised imaging actually revised because she had multiple CT images just 2 months before her presentation. We were looking just for any suspicious area of growing tumor. Renal ultrasound, Doppler repeated twice and came remarkable. So multidisciplinary team meeting done between nephro, cardio, and GI. We decided to, what she needs at this stage is pulse steroid. We gave her 10 milligram per kg, and the renal biopsy results came non-conclusive. There was just tubular injury. C3 goes with possible of C3 glomerulopathy, which is not correlate with the clinical picture, actually. Abdomen CT was normal. Renal ultrasound, as a Doppler ultrasound, as I mentioned, repeated twice at this stage and was normal. This is her investigations. It's few days after the pulse steroid, showed improvement in hemoglobin, dropped film and platelet, normalized ASR and CRP, and the drop in the cardiac enzymes, improvement in the BUN and creatinine. We know at this stage that we're hitting an inflammatory process, but there was no improvement in all parameters. There was a new onset rash, just 3 days after steroid, and she shifted from ward to PICU because of refractory hypertension. And this is the rash that she developed, and we say, another biopsy, another tissue to biopsy. Let's take a biopsy. It was not also conclusive. So at this stage, where the things are not progressing as you would expect, usually we ask ourselves, what am I thinking of? If I was wrong, how can I be sure? We ask these questions. We used to do that. But the funny thing in this case, the PICU consultant's office desk actually was just next to mine. And every morning, she's a brilliant one. And every morning she was asking me, Mit'aba, you gave her steroid and she's now in the PICU. I cannot control her blood pressure. Why did you give her steroid? What are you treating? I was kind of, I really need further imaging, but I'm stuck with the radiologist. They refuse to do CT angio because her renal impairment is not that safe indicator to go for such imaging without proper justification. She said, I can deal with them. We will hydrate her. If she decides to go to renal failure, we will dialyze her. We need to get that CT angio. And, you can force yourself, but you cannot force a radiologist. You can just convince them. So at that night, I tried to collect the articles that show the Crohn's association with renal artery stenosis, and exactly this is what happened. I captured one of the CT that showed CT angio, Crohn's with bilateral renal cirrhosis. I sent that photo to the radiologist in the middle of the night, and I texted her saying, I think this is what our patient have. And the next morning, CT angio done, and it showed this is our patient's CT angio, showed bilateral renal stenosis, more in the left side. You can see barely blood flow in the left renal, and the tissue of the left renal start to pale and shrinking. because of the decreased blood flow. So renal artery stenosis and thickened wall of the aorta revealed, and they give us impression of aortitis. And they said, in the other day, send her, we will screen the other vessels. So yeah, they also screened the chest, and we saw the ascending aorta, thickened wall here. The pointer is just the thickened wall. And number 1 is indicate the aorta, ascending aorta. And number 2 is the descending aorta. And number 3 is the left pulmonary artery, which were all inflamed. So according to ACR criteria, this is a Takayasu arthritis. And this is a diagnosis that come post-complication, which is never our goal. But I think it's worth to just take a few minutes looking back and think, have there been any clues with the benefit of hindsight? What I want you to know here is that the green text indicates the points that could have give us clue toward the right diagnosis, and the text in the red indicates the points that would have led us away from the diagnosis. So basically, constitutional symptoms is perfectly consistent with the Takayasu arthritis, but with the presence of IBD, we thought, it's her disease. There was an important question to be asked here. Is her GI manifestations was actively correlate with the serological activity? And the answer was not. Also, the pre-existing IBD actually can associated with Takayasu, and it's reported since 1980. And one of the largest cohorts showed that the prevalence of Crohn's disease in the Takayasu patient is 1 to 10. That means 10%. It's not that rare association. And it's different perspective than we have had approached this with. Another thing is that her initial complaint was lower back pain, and this is one of the rare manifestations of Takayasu arthritis. She didn't present with claudication. She didn't present with a different limb pressure. She didn't present with the pulseless disease. And this is the ugly face of naming the disease with inappropriate names. So if the IT can help me to move my presentation is stuck. So another point also to make there was this article that explains the aortitis pain. What is the pathophysiology of aortitis pain with the Takayasu beautifully explains the pathophysiology of that phenomena. So another thing that when we kind of give her steroid and we notice the improvement, we know that we hit an inflammatory process. But another crucial information has been given by the ICU consultant and said, whenever I gave her AC inhibitor, her BUN and creatinine raised in the other day. And that means we are dealing with the perfusion issue here. So, and that encouraged me that we're on the same page. So, again, one of the confusing things was really the repeated Doppler ultrasound that was normal. But we know the ultrasound is operator dependent, and there is a lot of factor can affect the results. Our patient was obese. So yes, this was a difficult diagnosis to make, but the management even more difficult. This is patient who flared and developed Takayasu while she exhausted 2 anti-TNF medications. And anti-TNF is the first therapeutic choice for Takayasu according to ACR criteria, according to Vasculitis Foundation guidelines. So whenever we make a decision, our decision should be rooted to evidence. And when you look to those evidence, you will see that those evidence ranging between low to very low evidence, Not very interesting, especially with our case. So, if you were in our situation, what would be your choice? She's having Crohn's disease and developed Takayasu. She previously was on infliximab and adalimumab. What would you give her? عن خاطري يا ربي نحط عن خاطري يا ربي اشتغل. So, Annie, you can speak up, just tell me, what would be your choice? Tocilizumab, rituximab, that's a big gun. Another? So, yeah, we choose to go with tocilizumab. So another decision to make here, how fast should we push her for vascular intervention? You know, nobody wants to touch inflamed vessels. And the recommendation said you have to get patient in remission at least 3 to 6 months before planning for surgical intervention. Yes, but we are talking about 14 years old girl who are sitting in the PICU for the last couple of weeks, who is having deteriorating kidney function test. And this is her DEMSA scan. You can see that the left kidney started to shrink and the function decreased. And she developed manifestation of congestive heart failure. We know that if she left in that track, she would end up having scarred kidney, renal failure, and congestive heart failure. So we decided to, we're gonna involve vascular surgeons. They were not that happy about it. They said nothing to be done. We, again, start to communicate with other more experts who offered her surgery. 1 week later, she had right renal bypass surgery. You can see here her left renal with the kinked tortuous renal artery. This is the one that was not touched by surgeon. And the right renal, they did aortic renal artery bypass. And this is 1 year later. 1 year, she's on tocilizumab, steroids, and we decided to take imaging for follow-up. Unfortunately, there was still persistent active disease at this stage, but she had no symptoms almost. And the good thing that there was no new vascular territory. This is her abdominal MRA showing thickened aorta, which indicates still active disease. So at the end, all this to say that Takayasu arthritis remain a challenging diagnosis to make. And it's really need high index of suspicion. It might present with constitutional symptoms rather than the damaging or ischemic manifestations that we usually looking for in our clinical examinations. And again, it can surprise you behind the face of other autoimmune disease. It is associated with, can be associated with IBD, Crohn's and ulcerative colitis, spondyloerythropathy, and rarely also sarcoidosis. And the last thing for the fellows and trainees, you will see those cases. Those cases are not rare for our specialty. And when you face such case, try to communicate with others, try to involve whoever you can, because you might miss the diagnosis, you might not reach the diagnosis, but you want this to be honest misses, not negligence ones. So act when you need more data. Fight with radiologists sometimes. But yeah, this can change the tragedy for the patients and their family. I spent around 20 minutes telling this story, but this patient actually spent 5 months in the hospital. So just remember that, and thank you very much.